I very much appreciate the chance to be here and to talk about healthcare, which is a critically important issue now, and I'll get into some of the why I think things may change, and why I think they may change in a bold way, like I'm hoping they will change, and get into all of that. And can you see this okay, or is it? If you can dim the light at least up here, whatever, either dim or off, either way. Okay, that's fine. That's okay? Good. My pitch, and by the way, I can pitch my own book because I promised not to make money off of it, so I'm not making money, so I don't mind hawking my own book, or HCAM is actually selling it to raise money for Healthcare for All Minnesota. But I picked the title for the book, Healing Healthcare, because of the fact that our healthcare system is sick. The Affordable Care Act helped on it. It helped address a lot of the problems. It cut the number of uninsured people in the country by half. Actually did about the same in Minnesota as well, but we were ahead of the rest of the country in how many people had some sort of healthcare coverage. But it did wonderful things for a lot of people, but it didn't fundamentally do anything to change what's dysfunctional about our healthcare system. Now I'm very deeply concerned, as I think a lot of people are, that what's going to happen in Washington will make the system worse. Largely because most of what some have called Trump care, what the ACHA was, and so on, was largely a decision to take a lot of money out of health care and put it into tax cuts, which you can favor or oppose, but you can't argue it's doing anything for health care. And most of the reforms being talked about aren't things that even the proponents will say, well, this is going to address the problems of the system. They're usually, well, this will patch it up for the next year or two. In Minnesota, we passed a bill for an insurance subsidy thing this year that we spent about $800 million on, it may be a little bit less than that in the end, on subsidizing and trying to fix the individual insurance market, which is about 5% of Minnesotans. And it is a temporary one-year fix. I didn't think this was a good idea. I don't think the system should be having more money put into it. I think it should cost less, but you got to fix the system. You can't just take money out of it or you're cutting people off health care. And the whole concept that if we take away somebody's health care, the people who can't afford it or barely can afford it, you take away their access to health care, that doesn't really save money. It would if the people who are often very sick and unable to pay for it would cooperate and stop getting sick, but that's not the way the world works. And you take away somebody's access to health care, they don't stop getting sick, they often get sicker, and somebody else ends up paying the bills. So my end pitch is I think we can and we must heal healthcare system. And I was going to start by this saying why this matters. This is an online cartoon I saw this summer, and I called the cartoonist, who happens to be from Maine. I looked up his number, or emailed him and contacted him, and he said I could use it. I thought it was a good illustration of what we need. For those who don't know, a GoFundMe campaign are the internet things where you raise money for some cause, or some people for a business, and obviously some for health care. But he says, in my experience, Americans help one another. We may disavow community, but we actually use it to get through many of our troubles. He talks about this guy named Shane that he met in a college comics writing course. They're both comics writers. Soft-spoken, sweet, wrote strange stories centered on life in Houston, and founded Zine Fest. It's not my generation. I'm not sure what Zine Fest was, but his cartoon had a frame saying an event dedicated to promoting zines, mini comics, etc. Anyway, he says he graduated, left the city, but they kept in touch with each other. Yet somehow I missed things. I knew he moved. People were doing that after college. I never thought anything of it. I left the city because I couldn't afford it. But I never knew he was diabetic. Never heard him tell anyone about it or his struggles to find medication. He left the safety net in Houston because he had to go help his mother, who was dying in Arkansas. Without a job, waiting for his insurance under the ACA to kick in Arkansas, he turned to the crowdfunding site GoFundMe to campaign for his insulin while he cared for his mother. $50 shy of his goal for over 2 weeks, many of his friends not being aware the campaign existed. Shane died March 18th of this year, 2 days after his mom did. He says, I've since read up, I'm not a medical person, by the way, so I read this is new to me, what it is, but diabetic ketoacidosis, horrific symptoms, vomiting, abdominal pain, shortness of breath. Shane died in horrible pain. The comic writer took one frame here to explain, here's how we fund our healthcare, here's how we take care of ourselves with healthcare in this country. The biggest gray plot is employer insurance, Medicare and Medicaid are some of the big ones, individual market, on and off the exchange, uninsured, etc. He says, I think of my brother between jobs in rural Maine without insurance, and Maine was a state that refused to expand Medicaid. His sister with her heart problems, his spouse with a history of diabetes. And I think of Shane. I think of Shane dying, I think of $50. And the reason I tell you this is because I think many of us know people who have suffered like this, but this is not just an academic thing. Why do we care about this? Because I can guarantee you this health plan I'm proposing doesn't have the greatest chance in the world right now. I think it's got a very strong chance in 4 or 5 years. But it's easy to just think, well, yeah, it's public policy. I deal with that at the Senate, have done it for many years, and try and make life better for people. But when you see these things, and I know stories of people, I know a woman I actually met from DFL activism in the Twin Cities whose sister was a nurse, 48-year-old nurse, lost her job in the recession 10 years ago. With it, she lost her health care, and she's dead now as a result of that. I mean, this happens to people. And so to me, we've got to heal our healthcare system. And I'd say it's a moral obligation to do that. But I propose, and I'm just spelling out what I would try and do, I'd propose what I'd call a common sense universal healthcare system. And I added the line funded by a single payer, because this is what you'd call a single payer system. I don't usually use the words, but I will explain why. What is single payer? Well, it's a system where our medical expenses are paid by one entity, not multiple ones, not insurance companies and government, businesses, individuals, and co-pays and this and all kinds of thousands of different sources of funding. It has a single entity that pays the medical bills. It's not a very descriptive term, however. If you buy a new car and I ask you, well, what did you buy? Dealer financed. Well, yeah, okay, but what kind of car did you buy? Dealer finance, and you really insist. It doesn't tell you a lot. And accordingly, people, they don't always know what single payer is, but they know it's a good thing or a bad thing depending on their politics or something else. I also think it's probably the only way we could get universal health care in American politics. There are a few European countries that have a multi-payer, multi-insurance company system. They actually do have universal health care. Germany is one and so on. But the difference there is in those countries, the government tells the insurance companies who they cover, which is anybody who comes to them. Their sickness funds, as they call their insurance plans, started out somewhere from unions, some were from local communities, some were various employers. They used to have thousands of them. It keeps whittling down to fewer and fewer. But bottom line is, if you are one of those funds, if somebody comes to you, even if they're not from your town or something, you have to take them. What you have to cover, that's all prescribed, which is pretty comprehensive. What you have to pay the providers is all spelled out. Which providers you use is virtually anyone. So the government tells the insurance companies what they got to do. In our country, it's kind of the other way around. Insurance companies and others tell the government what we're willing to do, what you got to do if we're going to do that. So I don't think we'd get a universal system anyway other than this. People say, haven't we? We've tried lots of things. Affordable Care Act is one. Why it didn't work, or it worked in many ways, but it didn't fix things. Why should we trust this proposal? Well, this is a long list, and this isn't a comprehensive list, but there were over a dozen, I think there were about 14 healthcare commissions or task forces that were appointed either by the governor or legislatures over the last 30 years. This is not the last 3-4 years, but the last 30 years. One after another, these are the things, and I served on 3 or 4 of them. We worked very hard, long hours, good, smart people, and we basically, I'd say, tinkered with the system. What do I mean by tinkering? It's to improve something with small changes, fiddling and adjusting with it, but some little bits of progress maybe. But even if all the recommendations from any of those task forces had been fully implemented, none were ever fully implemented, but even if they had all been fully implemented for one or the other, we fundamentally wouldn't have changed the direction we're headed and what the problem is. What have all these task forces been addressing? Well, they've been trying to address certain problems. The most obvious one is healthcare is too expensive, and the solution they've talked about largely is let's make it more difficult to get. Anything that's too expensive, buy less of it. How did they do that? Well, we try limited networks. As a kid, I don't remember such a thing as networks. Somebody's in network or out of network. That's a more recent thing in the last several decades, where you can go to these doctors or these hospitals, these clinics, limited networks. Co-pays and deductibles. You pay this much before you get to see anybody, and so on. And that did help restrict some care, so people put more and more co-pays and deductibles in. So we have to have insurance to cover some of the co-pays and deductibles, and the federal government subsidizes some of those out-of-pocket expenses. But basically, that helps restrict care. We restrict coverage by not covering more and more things. One of the proposals that was offered in the Minnesota House of Representatives, and very similar to the ACHA in Washington, is we're going to have, well, we don't need a comprehensive insurance package. If you don't have diabetes, why do you have to pay for diabetes care? You don't have cancer, you don't pay for that. And kind of it's called, I call it the Swiss cheese theory of insurance. Lots of holes in it. And if you're healthy, you might be fine. And the difficulty with healthcare is none of us really know what the future holds for us. And then prior authorization is one of the other tactics we've tried. Before you get certain coverage for expensive things, you have to get approval from the payer, from the insurance company. You have to get prior authorization. If you talk to doctors and nurses, how many hours they spend on the phone trying to get this for things they know is going to be approved because it has to be, because the person needs it. It's a terrible waste of time. It's gotten to the point now where people with diabetes actually, in some cases, have to get prior authorization every 6 months to get their insulin. It's a bizarre system, but we've tried all these things to make it more difficult to get. And, you know, it's had some effect. Americans do use less health care. I'll show you a comparison on that in a minute. We spend twice as much as other countries. We have worse health outcomes. Some of that, here's the comparison. We do visit doctor less than people in other countries. If you can see this, United States, it's about 4 visits for doctor consultations in a year. Sweden, Mexico, Chile, New Zealand, Ireland are below us, but Japan and Korea are off the charts. I mean, some of that's cultural difference, but they go to the doctor a lot more than we do. We're not way out of line. I mean, it's not necessarily the best indication of whether it's a good healthcare system or not, but we're not overusing it. Our health outcomes far behind. Life expectancy, this chart is, if you can see the red line here, we are just under 79 years of age life expectancy. A lot of countries are doing 3, 4, 5 years better than us. We do beat Mexico and Latvia and Slovak Republic and so on. Another measure, infant mortality. This is one you want the low end, obviously. Iceland has about 1 per 1,000 live births. We are up at about 6. And again, we beat Mexico and Turkey and some of those countries, but we're not at the good end of this. We're not doing that well. And yes, we spend twice as much for healthcare. These numbers are from 2012, but the most recent numbers, they're just higher up, but they're roughly the same kind of curve. If you look at that, we're at this year, in 2012, it was like $8,400. Now it's about $10,000. So the midpoint of just over 4,200 or so, if you draw a line right through the middle there, you'll find there are about 7 or 8 countries there that are over half of what we spend. There might be 1 or 2 others in the world that are up there too. In other words, all but 8 or 9 or 10 countries in the world spend less than half of what we spend on healthcare. That's per person. And that's way out of line. Those that are above half are about 2/3 or less. I think all of this, if you spend all your time trying to make sure people don't overuse healthcare in order to save money, that raises 2 questions. First is the moral question: what kind of a society wants to make it difficult for its own people to get healthcare? I can see people saying, well, we want the people in that country, we don't want them to get healthcare, but you really want to punish your own society? I mean, it's kind of like education is also very expensive. Well, we don't want every kid to get education. You know, it's a waste of money. I don't care about those other kids. We don't want them. What kind of society is that way? And the practical question, if that strategy isn't saving money, isn't it time for a new approach? So a new motto, what might that be? Police and fire protection. Let's take a look at that. Nobody has to apply for new coverage each year. This is the time of year open enrollment starts for health care. If there's open enrollment for police and fire coverage, well, that's not something we really want to deal with. And if you have a fire at your house, you don't want to have to pay the $3,000 deductible before they'll come and help you. Or ask the sheriff if they'll accept your local police insurance plan. Any civilized society is going to make sure that its people have access to basic services like police and fire, and shouldn't it be the same with medical care, dental care, and so on? So when you go there, I mean, I told you earlier that this is what you call a single-payer plan, and I said, you know, that's a partisan, and the people feel controversial about that. I don't care if we have a single-payer plan at all. I really don't care if we fix the system some other way. If somebody's got a better idea, I'm open to it. But how do you get beyond the politics of, oh, I want this or that? I say what we should do, and we don't do this in many areas of public life, and we really ought to. And that is figure out where you want to go. When you're on a trip, where do you go? Where are you headed? In designing a healthcare plan, we map out the direction and spell out principles you put together on what you want to accomplish. Back in about 2003, I introduced a bill that spelled out what I thought were principles for a good healthcare system. That was during the Palenti administration. His commissioner of health was not somebody I agreed with a lot, but I had put together this list of principles and introduced legislation saying, hey, I would ask that Commissioner of Health that she would put together a plan that meets these principles. Why would I have somebody from another party design a healthcare system? If she meets these principles with her plan, I'll sign on. I don't care what it is. If you can develop a system that covers everyone, not 95%, which is what we have in Minnesota, not 90%, but 100%. And it covers all medical needs, including dental, including vision, including addiction treatment, including long-term care. People in this room may know it, but lots of people don't, that Medicare doesn't cover nursing homes. And I think many of you may know people who have gotten divorced or other things because they wanted to protect some of their assets, especially if it happened to a younger couple in their 40s or 50s where somebody's going into a nursing home so they don't lose their assets because the other spouse may live a longer time. I've known people who have gotten divorced because of that. But cover all your medical needs, mental health, prescriptions, etc. Let patients choose their doctors and hospitals. This network system is really dumb, and if people say, everybody says, well, we care about the patients. We want the patient-centered thing. Well, that's how you do it. You let patients choose who their providers are, and medical decisions should be made by those patients and their doctors, not by some outside entity. Reduce costs not by denying care, but through other savings, through, in this case, largely price negotiation, cutting administrative costs, but not by denying care or reducing quality of care. You want it to be affordable to all. Premiums would be based on income. Well, is that fair? Well, if you hear that 3% of the public, the American public, spends more on health care than 75%, than the bottom 75% spend, it's not because they want to, it's because they got severe disabilities, or they got serious forms of cancer, or they got very complex conditions, and they're very expensive. And I can guarantee you your ability to pay is almost, not perfect relationship, but it's almost inversely related to the ability to pay. The sicker you are, the less likely you are to be able to pay these expensive things. That's what insurance is all about. That's the concept of sharing risks and so on. But everybody should pay into it, and if you're low income, you can't afford much, so you make it affordable by having the premiums based on ability to pay. You focus on preventive care. We want to make sure people get health care when they need it, but we also don't want them to need more health care than you need, and we're doing a poor job of it. We do have a lot of public health programs. I strongly support the ones we have. I think we should be doing more of it. We spend about 0.1% of our health care dollars on prevention. We should be doing, but why do we not spend more than that? Well, it has to come out of other competition with other things. If it's all in the health plan says, we could save money if we invested in this. So focus on prevention. make sure there are enough providers to avoid waiting lines. Some people say, oh, Canada has waiting lines, and they do have some. It's not as bad as it's usually hyped around here, and they've got a system in place for addressing it, but there's actually an advocacy group trying to address it in Canada, and they've acknowledged there's been a lot of progress made. And they point out, because some people say, well, see, that's what you get when you get a universal healthcare system, and they point out, no, it doesn't have to have anything to do with it. How come other countries that have universal healthcare systems don't have waiting lines? And let's not pretend our society doesn't have waiting lines either for those who can afford to get in the waiting lines, but some kinds of care, psychiatric care, it's very hard to get. We don't have, and that means there's a shortage of providers. I think a good healthcare plan is going to take care of that. You want to maintain what you've got. We've got some of the best doctors, hospitals, clinics, research technology, I think I said that earlier, in the world, but the worst system for accessing it. That's what we want to fix. But you don't want to lose the good things you've got. We want to keep that, and there's a good way to do that. You want to pay, this is one that if you have nothing to do with the medical field other than going in for care when you need care, this may not matter to you, but yes, it does. If providers aren't paid on a fair and timely basis, you can't run a business that way, you can't run a hospital that way, you can't do it unless they're paid in a timely manner. So even if you don't think it matters to you, any good healthcare system is going to do that. And I'll say that both government and insurance companies often don't pay on time, and they fight things they shouldn't be fighting and so on, but pay in a fair manner. And finally, I think you want a simple and understandable funding and payment system. When I was a kid, I don't remember seeing these things that are called EOB, or estimate of benefits. When I first started getting them, I'm thinking it's about 10, 15, maybe 20 years ago now. I'm not good at remembering when. Start getting these things in the mail saying, this is not a bill. Then your question is, well, why'd you send it to me then? What is it? I mean, when they first came out, that was the question. What are they for? And they're very confusing. One of the simplest ones I ever had, I had neck surgery, expensive neck surgery 10 years ago in Regions Hospital in St. Paul, and the medical estimate of benefits, it was for the whole thing, and it was $21,000. And unfortunately, my health plan was only covering $7,000 of it. The good news is I only had to pay $200 of it. So who paid the other $14,000? Oh, that's written off, and that's all negotiated anyway. But that doesn't make any sense, and the amount of time people spend trying to figure out the bills it is a terrible waste of everybody's time. We don't count your time filling out insurance forms and getting all this done. We don't count that when we talk about the expense of our system. That's one that no other country has anything like it, and that is very real time. Figure out what your time is worth, and you got to remember you're putting that time in to figure out the bills and stuff. We want a simple system on that. I think every one of these principles is important. I don't think you have a good healthcare system unless you meet them all, so each of them must be adhered to. I became chair of the Health Committee in 2007, and I took that legislation with those principles and said, well, let's design a healthcare system around that, and I had not seen any others, so that's when we started putting together. It took a year or two to get the Minnesota Health Plan in shape, but that's what we did. Minnesota Health Plan would be governed by those principles. In fact, the legislation says it would be legally bound by those principles, which would make this the one health system that's focused on well-being and public health instead of profits and politics. As I said, it should be patient-centered. That second one about how do we focus on public health and so on, well, improve the quality of health. I'll just give you a couple of real quick things of how that makes a difference. First of all, dental care. It's not covered on most people's insurance. It's an extra. My employer provides it, but not everybody's does. Medicare doesn't cover it. Medicaid does. But, you know, what kind of a system are our teeth any less important than our fingers and toes? People who know medical things say that infections in your mouth are very serious to your fundamental heart health and body health. And yet we don't have separate finger and toe insurance. Why do we have separate teeth or dental insurance? Because we don't have heavy access to it, and because dental care is expensive. Minnesota in any year, this is a 5-year average, is about 33,000 emergency room visits for dental care. And I can guarantee you the Owatonna Hospital does not have a dental chair in the emergency room. I know that because only one hospital in the state does. Hennepin County Medical Center has emergency room, has a dental office right next to it. You go to any other one, they will give you Novocaine or some other pain relief, assuming you got an infection, which it usually is. They will give you antibiotic, and they will tell you, go see your dentist in the morning. They won't even pull your teeth. They may in emergency, or if you're there because of trauma, you were in an accident and your teeth were messed up. But other than that, they won't do it. And they tell you, go see your dentist, and you don't have a dentist. I talked to one woman from Mora, Kanabec County, halfway between Duluth and the Twin Cities a few years ago. She spent a full day trying to find access to a dentist. It was a Friday. She was in a lot of pain. She said, what am I going to do? And she said, I said, I'll try and help her find a dentist. But that was Friday night, and Monday morning we called her, and she had found a dentist in the Twin Cities, an hour away. And by then she had been to the emergency room 3 times. Think of the cost of that. School nurses. I got my polio vaccine as a kindergartner. That was about the year or 2 after they came out. We all lined up in the school gym, everybody got it. Why can't we have nurses with flu vaccines send notes home? You want your kid to have a flu vaccination? If they do, we'll give it to them. You'd probably get 80, 90% compliance. Instead, we get maybe half that, and we spend a fortune, because I know just from my own experience when our kids were that age, you have to set up an appointment at the clinic, got to go take time off work, pick up your kid at school, take them to the clinic, give them the shot, bring them back to school, disrupting the teacher's time, their day, and yours as well, and you get half as many people to do it. Home visiting nurses, there are things like that you can do. And one of the biggest things is providers. How much time doctors, nurses, medical professionals spend filling out forms, getting prior authorization, other things like that. You take all that stuff out of the way, doctors can spend time with their patients, which really makes a difference for healthcare quality. Minnesota Health Plan, how do I describe it? I think you could call it Medicare for All, because it covers everybody over 65 and everybody under 65 as well. You could also call it Medicare Plus, because it covers all Medicare benefits plus dental, long-term care, and things that currently require supplemental coverage. You don't need Medicare Part D. You don't have a donut hole. You don't have co-pays or deductibles. Government health care. When I introduced the bill this year, we got a whole bunch of authors and decided, well, we'll have a news conference. We knew it wasn't going to pass this year, but I wanted to put it out in front because we were having a lot of healthcare discussions at the Capitol. And I guessed what the first question was going to be from a reporter at the news conference. Isn't this government healthcare, and isn't that what people don't want? And I said, well, you know, when I hear of government healthcare, I think what I hear and what I know people don't want and I don't want is government telling people what kind of care they get or what doctors they go to. And if people say they don't want government health care and they're accusing this bill of being it, they should read the bill. It's only about 30 pages long, and you can kind of see government has no role in that. It's a patient and provider-based system, and I don't want government, I don't want employers, I don't want insurance companies telling people which doctors and clinics they go to, nor do I want them telling them what kind of care they get. Biggest question after all this presentation of that is, we can't afford what we're doing now. We're spending way too much on healthcare. How are we going to cover more people for more things? And the answer is, and it may sound counterintuitive, because you know you're covering more people for more things, and we know more people getting more care is more expensive. So the answer is obviously what I was trying to say there is it's counterintuitive, but it actually is cheaper. We had a Healthcare Access Commission in 2007. I was served on it. We came up with some recommendations, I think made some small improvements. Public health program we started up and so on. But Colorado at the same time, they took a different approach. They did sort of the Amazon approach. Come on, give us your best ideas, an RFP, a request for proposals to the public. What are your best ideas? 24 groups came in, offered proposals. A lot of them are pretty similar and so on. They whittled it down to the best 4 and worked them out a little bit. They studied them. Then they hired the Lewin Group, which is a health economics consulting firm, to analyze them. They put out a 250-page report, and I made this little chart. I'm not from Colorado. I have no ties to Colorado. But I thought it sort of spelled out nobody's going to read the 250-page report. So I listed the 4 plans. If you can't read these, Better Health it doesn't matter what the names are, but there are 4 different proposals. A couple of these were very similar to the Affordable Care Act. This is a couple years before the Affordable Care Act kicked in. And Colorado started with 800,000. I made two columns. Their two goals were to cover more people and save money. First column, they started with 800,000 people. The first one cut it almost in half, which is about what the Affordable Care Act did. It cut the uninsured population nationwide about by half. So it cut it by half. Next one, all the way down to 138,000 people from 800,000. 109,000. The bottom one, the one thing I'll point out is this is a universal health care system. So maybe you can guess the number here, but it doesn't take 6 digits. Nobody is left uncovered. It covers everybody. Cost increase in health spending was just under 600 million. This one was actually a cheap one, 271. This one, 1.3 billion. And the universal one had the biggest number of all, but there has a little minus sign in front of it. It actually saved money, which was their goal. Remember, they wanted to cover more people and they wanted to save money. So what happened in Colorado? Only one plan covered everybody. Only one plan saved money. In effect, only one plan worked. However, experts decided a universal single-payer plan wasn't feasible. So, you know what they say, if it's not feasible, we'll find something that is feasible. And that's what is the way we do things. If this isn't feasible, we'll look for something that is and we'll fight for that. I'll say the same thing with different words, however. Experts decided the one plan that worked isn't feasible, so we'll pick, instead of fighting for something that works, we'll pick something that doesn't work and we'll fight for that instead. Now that sounds really kind of dumb, but it's the same thing as saying if one plan works and you're saying we're not going to do it because it's not feasible, when you're saying, well, we're going to pick something that doesn't work, which doesn't sound as good as saying we'll pick something feasible. But I'd argue, isn't that the way we ended up with the Affordable Care Act? You know, we really want to cover everyone. President Obama was very articulate in his first campaign about health care for everyone, and then, but, you know, we can't really get there, and so on. So came up with something, and so we come up with something that doesn't really fix the problem. If you can't read this comic strip at the bottom, it says, the guy's reading the sign, it says, it sort of makes you stop and think, doesn't it? Which is what I think we ought to be doing thinking about how we're doing this. Think about whether it's time for a new approach. Now, I didn't spend much time other than that Colorado chart on telling you and the comparison between international comparisons on saying that economic studies and international comparisons suggest that a universal single-payer system is less expensive, even though it covers more people. And you can say, well, I'm going to say, well, it's through price negotiations, rational pricing in effect, not 15-to-1 price disparities on things, and through administrative efficiencies. But, well, I know, but, you know, John, we can't afford it anyway. It's too expensive. How do I say, to make it clear how big of a difference this stuff, what a difference it makes, let's consider what would happen if our schools were funded like hospitals. And excuse the cheap art, but that was my attempt to show the school and hospital. If schools were funded like hospitals, education would have a lot of things done differently. Every day, teachers would have to spend time calculating how much time and supplies they spent for each student. And it's not like 20 kids in the class, they all use the same. Some need a lot more attention. Special needs kids are off the charts in the attention they need. Administration would have to have a billing office to allocate overhead, capital expense, janitorial expense, and so on. And I don't know, maybe in Owatonna you do things differently, but in Roseville and so on, we don't have billing offices in our schools. Parents would have to purchase school insurance plans, and education is very expensive. So of course, employers would begin offering school coverage for their employees' children because it's too expensive for people to buy on their own. And so we'd have a system where employers now have to get in the school coverage. And of course, if you don't have employer coverage, you'd buy it in the individual market, and we'd probably set up exchanges for it, and the government could subsidize it for people who have trouble. And government would step in and subsidize if we care about kids to make sure they all get an education. School billing office, every month they'd send out bills to the school, to the students in their school insurance plans, and the prices on them would be a charge master. Anybody who works in a hospital knows what a charge master is. To those of us who don't, it's just that mysterious formula they have that triples the price of everything in irrational ways. Why do they do that? Well, school insurance plans have to negotiate with the school. They're going to fight to get the discounts they think their members deserve. They're doing something for their members, so in effect, they may be paying fairly close to rational prices in the end. But the families who don't have insurance are going to be stuck with paying the full rate, which, like in my neck surgery, $21,000, it cost $7,000 in reality. If you don't have the insurance, you'd pay the $21,000. Even families with school insurance may not be able to pay the copays and deductibles, so schools would need a collections agency as well. Would this improve education? I don't think so. The biggest thing is it would take principal time, teacher time. Let's not forget parent time with all this billing rigmarole. Parents ought to be spending more time with their kids. We want that. We don't want them spending more time on billing and paperwork, but that's what we'd be doing. And some students may be forced to switch schools because they switch employers, or you get different plan and your school's out of network. Some students might be denied an education because their parents didn't have a school plan. But again, the schools, I think a lot of schools would say, well, we'll educate them anyway. We'll cover the uncompensated care by shifting the cost to other people. Would it save money? Of course not. You'd have to pay for all that billing and collection bureaucracy. It would cost a whole lot more. There are additional complications like out of network, and you don't know who's out of network if some of the teachers in the school are. You won't know that till you get the bills. Now, why, with the system we have there, and I don't think anybody would choose to do that, but this is a chart showing the growth of healthcare physicians and administrators in a 40-year period from 1970 on. This is growth in physicians. This is a very steep, compressed chart. It's actually almost a tripling of physicians over that 40 years. Administrators have grown a little bit steeper rate than that. And you can see that. If you went back to the school analogy, you can see how many more bureaucratic things we'd have to do to handle all the complicated things. And the more complicated it gets, the more companies come in there and help. There's a new business in Minnesota. It really is a useful business for an employer. They promise for a fee, I don't know what it is per employee, $50 per employee or something, they will scrutinize all your employees' medical bills and find errors in it. And they can guarantee you they're going to find you more than $50 a person in savings. One bill of $10,000 of error in a hospitalization or something pays for their whole thing for a pretty large firm for a year. That's a new business, and they don't provide any health care. They just make it more efficient for the people in it, making it more convoluted for everyone. What about a public option? That's often talked about. The Affordable Care Act had a proposal to have that. It might be better than other plans, but again, you go back to the school analogy. Supposing we had, for the school plans, you had Blue Cross for education, and Health Partners might be education partners, and UCare might be ULearn. You have good plans and so on, and we could take Minnesota Care, which is the so-called public option in Minnesota, have Minnesota Learn, and it might be a better plan than the other ones. It might give you better benefits and lower premiums or something. But why do we want all these plans in the first place? Isn't the goal to educate kids? Isn't the goal to provide health care? What about loss? This is one of the things. When you start talking about a system like this, it's very expensive. Yes, it's cheaper than we have. It's got other problems. It would cause layoffs of people in the insurance industry. And I don't think, the reason I put a slide up here, this is not meant to be a promotion without saying, there are things people aren't going to like. It would displace people who are in the billing, not just in insurance companies, but in hospitals. There are people who do this. And I think you have a moral obligation when you're going to displace workers to take care of them. Not just unemployment compensation, but job retraining and dislocated worker benefits, because when you displace a lot of people, you got to do something about it. The Minnesota Health Plan would be legally required to do this. And the biggest thing is, though, if you have layoffs nowadays, the first thing you got to worry about, I think I mentioned earlier a friend who had a sister who was a nurse who was laid off and lost her health care, and she lost her life as a result of it. One of the biggest problems for people who are unemployed unemployed is they've now got, on addition to finding a job, trying to how to pay the rent, they got to figure out how they're going to deal with health care. These folks wouldn't have to. They'd be covered by the Minnesota Health Plan. From day one, they'd be covered. So that's one benefit, but you do have to retrain a lot of people. The good news is not everybody, first two good news things. One is not everybody needs retraining. A whole lot of the people who are working in medical paperwork stuff, a lot of them have medical training. Tons of LPNs and RNs that are doing mainly paperwork. We need their help in providing health care. And you know, the CEO of United Health Group, Bill McGuire, the previous one, he was a physician. He wouldn't need retraining. We probably can't match his $105 million salary, but you know, he wouldn't need retraining. But we do have to take this seriously, and the reason I point it out here is because I don't think we should duck these things. They're very real issues. What about long waiting times? As I mentioned earlier, that's the sign of a shortage of providers. It doesn't relate to single payer. I think I mentioned in Canada there's a group who was pointing out, you know, other countries with universal health care don't have waiting lines. How do you address this? I told you that the Minnesota Health Plan would be legally required to do that. In this country, we have too many specialists, doctors who are specialists, not enough general practitioners. University of Minnesota, when you combine it with UMD, actually does better than most other med schools in terms of number of general practitioners they provide as a ratio. But if we're providing too many of one and not enough of the others, how are you going to do it? You're going to force kids, nope, kid, you're going to study this. No, you don't do that. There are plenty of ways. That's where the market works. It works very well. If the system says we need more general practitioners, well, okay, if you med student who's going to end up with $250,000 debt, regardless of whether you're a general practitioner or a neurosurgeon who will get paid 4 times as much, if you're going to go into general practice, we'll pay off your student loans or we'll buy down your tuition. There are plenty of ways you can do it. Or we'll pay more to those professions, because you'd pay less to some things, you'd be paying more to others in a rational system. And the other problem is there's some parts of the state, Owatonna may not have the trouble getting providers that some further, more remote communities have, but it is hard to get people to go into certain fields in some small communities. It's hard to attract doctors. Well, you know, often when the state dishes out money for education or something, teachers in the metro area might do better. Well, cost of living's higher and so on. Well, if the health plan is required to make sure enough people to meet the needs, they may have to pay a lot more for people who serve in rural communities. If you're a general practitioner in the Twin Cities, you may never be on call if it's a big enough practice you're part of. If you're in Thief River Falls, you might be on call every weekend. You may have to pay more to get somebody up there. But the health plan, the reason we don't have the right mix of providers is because nobody's in charge of it. If you have a health plan that's legally required to do it, you do that. And that's what a rational pricing system does. They say we need more people in this field. We're going to have to pay more to get them here. Minnesota Health Plan, I'd say it's a comprehensive proposal for common sense system. We had hoped to push for it this year. I wrote that book last fall with the hope of January 2017, the Affordable Care Act said states can have these, it's time in 2017, 7 years after it was passed, you can get innovation waivers for the state. You can develop your own system, and if it meets certain basic criteria, we can give you a simple waivers to get the federal approval you need. So I had hoped to push it this year. Politics intervened. The election results in 2016 made it so this is not something that they're willing to consider. I would argue unpopularity of the Affordable Care Act was a big part of that. Matter of fact, Mitch McConnell in Washington said the same thing nationally. He claims that the Affordable Care Act cost Democrats the majorities and huge losses in 2010, a few months after it passed. 2014, the year it was implemented with the exchanges, and again this year. But in any case, now why am I pushing this? Well, first of all, I keep telling people, well, they say, John, your thing's not going to happen this year. I know it's not. But I can tell you, when the proposals out there, both on the table in Washington and here, aren't fixing the problem, we're going to have to fix it sooner or later. And it's such a deadly issue and so expensive, we're going to have to fix it sooner rather than later. And I like to quote Winston Churchill. It's not an accurate quote. He didn't really say this. I'll say that up front. But he allegedly said, the American people will always do the right thing after they've exhausted every other possibility. And I'd kind of make the case we're about the stage where we've exhausted every other possibility. So as you prepare for change, as the system breaks down even more, which I think it is, we're going to need Minnesota Health Plan. How do we get here? Real quickly, I didn't mean I want to quit now and go till about 8:15 with questions. We can stay longer. But this guy pictured here is Senator Max Baucus from Montana. He was the author of the Affordable Care Act. When President Obama signed the bill, he said he's the guy who designed it. He's the guy who put it together. He said at that time, it's not on the table, single payer. It was the one thing he said is not going to be considered. Why? It doesn't have a chance. It can't pass. We're not going to consider it. And many politicians who claim to support health care for all aren't going to push for universal health care. Affordable Care Act is a perfect example. It didn't cover everybody. And my concern, by the way, is not just the 5% of Minnesotans who don't have insurance. Some people say, we only have 5% more to go. I'm concerned about that 5%. We all should be. But I'm also concerned about the other 95% who have insurance, but it doesn't cover dental. Or they got co-pays that are out of their range, or they got deductibles of $3,000 and things that aren't covered. You know, we should be concerned about all of them. But he said, he was one of those who said it can't pass. Why doesn't it do it? I'd argue there are a couple of reasons. The biggest one is politicians receive big dollar contributions from the industries that profit from the current system. That's the way our political process has worked. Max Baucus, because he was chair of the committee who writes these things, he got like $600,000-$700,000 from these industries in the 4 or 5 years before this bill passed. He was a key player. They give him more money. And that does influence you. That's why I spend a lot of time trying to change the big money in politics. I think it corrupts our democracy. Other reason is politicians who like universal health care are afraid single payer is too controversial. It could cost them the election, so they're very timid about it. But I'd argue things are changing. First of all, Max Baucus now supports, he gave an interview in Montana a month or two ago saying, you know, he thinks that single payer is what we need, and he thinks it's going to happen now. It would have helped a lot if he had done it 10 years ago when he was in charge. He's now retired in Montana, and he can't do anything about it. But he did change. In Medicare for All, there were no proposals in the Senate a couple of years ago. Now there are 16 co-sponsors. Things are changing. Real quickly, here's my book. If you want to take a look, you can download it free at mnhealthplan.org. Happy to take it, open it up for questions and so on. And I had hoped to leave a full half hour, but we can go till 8:30, but I've suggested maybe 8:15 unless people really want to go beyond that, and I can stay around after for a little while. So let's open it up for a discussion. Yes?
With regard to your Colorado examples, when it was obvious that care would be better and the cost would be lower, and the pushback was that it wasn't feasible, what were the facts given to affirm that it was not feasible?
Okay,
when it's not feasible?
That slide, when they did it, the commission just kind of said, well, here, we'll just show you what we've got, and we're not going to push anything in particular.
So they offered no explanation?
It wasn't like a conscious decision, we're not going to do this, but everybody, the conversation was, this may make most sense, but it's not going to happen, so we're not going to push it. By the way, in those charts, because I want to make this clear, when I mentioned who the economics consulting firm was that did the analysis of these proposals, it was the Lewin Group. The reason I mentioned that, it's a Minnesota company. The Lewin Group is owned, the parent company is United Health Group, the largest health insurer in the country. And the reason I say that that matters is because I don't know if I'd do the same kind of analysis they do. I'm not an economist, but I wouldn't do it quite like they do. But they're not biased in favor of a single-payer system. It would put their parent company out of business. So I can guarantee you, that's why I mentioned who the consultant was. It's not, they got somebody who likes this kind of stuff and they hired them to do the analysis. This was the Lewin Group who did it, and they were being honest. And they figured showed it. But no, there was no conscious decision. Affordable Care Act was actually, in 2003, a rising Democratic star said, he thought single payer was the only way we're going to fix the system. But he said, we're not going to get there right now. This was 2003. He said, we need three things we don't have. One is a Democratic majority in the U.S. House. Another is a Democratic majority in the U.S. Senate. And the third one is a Democrat in the White House. 5 years later, that guy was in the White House. He told some group in Illinois in 2003 that he thought single payer was what you have to do, but you need this. He was in the White House in 2009, and he had Democratic majorities in both houses, but he said the same thing Max Baucus said, you know, it's not going to pass. And I'll agree, it would not have passed in 2009. This didn't pass either. 2010, he did pass the Affordable Care Act. I would argue, if he said, look, you know, we're going to stand up to the industries that want it this way, we're going to fix the system, we got to do it for people, we got to do it. And he goes around country that fall doing what he did anyway, campaigning for Democratic candidates for Congress, saying, you know, send me people who stand up to the powerful interest groups and deliver health care for everyone. I think the biggest change would have been that in November, Democrats wouldn't have gotten slaughtered. They would have picked up seats. Would they have picked up enough to pass it? I don't know. I think the thing is, they didn't want to try because it wasn't feasible, and what they did was feasible, but it doesn't work.
Who is the single payer that we're referencing? You said it wasn't government.
The single payer in this case would be the Minnesota Health Plan. It would be.
Is that a group?
It would be. I'm going to say that you could call it a quasi-government agency. Matter of fact, it would be elected right now. I don't know if Steele County is in a. I think Steele County is in a county-based purchasing system with several other counties. South Country. What? South Country Health Alliance. Yeah. Okay. You're one of several counties in that. What we would be doing, those systems are run by county boards. What we'd be doing is regionally around the state, we'd be having county boards elect people to a regional health board like the county-based purchasing system. And then those boards would each send representatives to a statewide board. That would be the one running it. So it'd be like the South Country Health Alliance. It'd be like that, only a statewide one, Minnesota Health Plan. You could call it, it's a quasi-government thing. The governor doesn't make any appointments to it, nor does the legislature, except the one thing the governor does is appoint a patient ombudsman, somebody who has legal standing to fight the healthcare system if they're denying somebody something they should get, or if they're messing up something. They are a patient advocate, and they have legal authority to force the health plan to change, and that would be the only gubernatorial appointee. Everybody else is separate from it, totally separate from the legislature. These premiums based on ability to pay, they would probably be collected by Department of Revenue, state agency. Unlike taxes, though, they would not go to the state treasury. They'd be kept like Social Security, totally separate. They go straight to the Minnesota Health Plan. So it would be a democratically selected board running you could call it a quasi-governmental or public-private partnership. I don't know what you want to call it, but it would be that. So you could say it would be a government governed kind of thing there. It would be funded by that single payer entity. But the care and so on would be the patient and provider-based system that I think we need. I hope I can go into more detail if people want that.
If that Minnesota healthcare plan were to pass in Minnesota, what about people that are already on Medicare? Would they be able to go off of Medicare and get this plan instead?
What we'd be asking, and I mentioned the reason for waiting till this year, which then didn't work out, but I mean, I didn't have a chance other years either. I'm not pretending like my goal was to have something happening in 2017. But the plan would be to put 100%, 5.3 million Minnesotans in it. If you have Medicare, what it would be, the change would be, you would now have, you wouldn't have co-pays, you'd have dental coverage and everything else, but it would be shifting everybody into it. And we'd be same thing with VA. We wouldn't be shutting down the VA. Veterans could go there or they could go elsewhere. But we'd be responsible for paying the bills for the VA in Minnesota. We'd be responsible for paying the bills. We'd be asking the federal government for waivers so we can take all the money they give us, including through tax, the tax subsidies they give to people for their employer-based premiums, including for the subsidies under the Affordable Care Act. All the money the federal government is offering, and now when they say block granting, I'm not saying what they're trying to do is a terrible idea, but we're saying, look, give us our fair share, give us what we've been getting, plus the inflation that happens with healthcare, and let us be in charge of it. The thing we'll promise instead is that We will provide seniors Medicare plus all the other things. And we will provide veterans VA plus everything else. We'll provide low-income people plus everything else. And I don't want to make this sound like, wow, this is just wonderful. Everybody, a healthcare system's not a fun thing, and it's very, very expensive. We spent $51 billion on healthcare in Minnesota last year. About half of it by government, about a quarter by individuals, about a quarter by businesses. That's grown to $55 billion, the projections are this year. If we saved, say we saved 10%, that's $5 billion in savings. I can't guarantee that we're looking for economic analysis, but yes, you'd be folded into it. And people say, oh, this is going to be confusing. How would we make the transition? For an individual, people who are on Medicare already know what the transition from previous coverage to Medicare is the day they turn 65. Now, you can still go to the same doctors and stuff, but somebody else is administering it and so on. It'd be the same thing, only now it'd be Minnesota Health Plan, which would be Medicare plus. Yes?
What kind of response are you getting from employers themselves? Their employees would be on this rate.
Right.
Okay.
Yes.
Are they happy about that?
Some, I would argue, a lot of, you actually had a video, I'll hold this up. There's some Pennsylvania, a fairly large employer, I don't know the name of the employer, but this is available actually online. It's called Fix It Healthcare. Yeah, fixithealthcare.com. Anyway, this employer, he started looking at, he said, he's in a manufacturing business. He said, when you look at how we're dealing with pennies make a difference in margins for us, whether we can compete and so on. He says, I look north of the border. In Canada, the employers don't have that kind of expense. He says, we're just killing ourselves. Warren Buffett told his Berkshire Hathaway shareholders this May or whenever they met their annual meeting, he said, business communities always complaining about corporate taxes. He says in the 1960s, corporate taxes were 4% of the gross national product. Now it's down to 2%, and they're complaining. He's not saying they shouldn't. He's saying healthcare in the 1960s was 5% of the economy. Now it's 17% of the gross domestic product. And employers are paying about a quarter of that. Far more than they're paying in corporate taxes. On average, they're paying far more than that than on corporate taxes. He says, we should be concerned about that. He described it very graphic terms. It's the tapeworm of American competitive economy. It's eating away from the inside. A great terminology, perhaps. But anyway, but a lot of employers, they know that they're worried about it. But I mean, I think I've talked to some small businesses the other day. They actually came to me because I contacted the team that was putting together Minnesota's bid for Amazon and said, rather than give subsidies for them, because when you're giving subsidies to one business, you know who pays for it? Other businesses. And frankly, a lot of small retailers and big retailers and everybody else are competing with Amazon. We're going to take their tax dollars and give it to somebody else. I'm pleased the governor and so on did not include subsidies in there, but I was suggesting, my offer to them was, why don't we offer something like the Minnesota Health Plan to Amazon? They'd have to pay for their share of it, as would everybody else. But it would take, first of all their employees would be covered cradle to grave, including their employees' kids. They don't have to worry about it. They don't have to negotiate a new plan each year. They don't have to worry about all the hassle. They don't have to deal with any of that stuff, and they'd be saving money. Why not? And I suggested that would be a bigger gift to them than maybe not New Jersey offering $7 billion to them, but it'd be a bigger gift to them than most others. And the thing is, even if they rejected it, the rest of us would benefit. And if they did come, the rest of us would still benefit. So I think it should be a great thing for employers. I actually, 4, 5, 6, 7 years ago, I was down in Owatonna and I actually met with Chamber of Commerce and others. It was a small group, but talking about why I think this is a good thing. And I think there was some interest in it, but a lot of questions by people. And they ought to be skeptical. I'm actually interested in taking this book and writing this Healing Healthcare book and writing the same book with a red cover and adding one word as a case for, let's see, the title is The Case for a Common Sense Universal Healthcare System, and adding one word, The Conservative Case for a Common Sense Universal Healthcare System, and focus a little more on some of the questions that I think I would hear from Republicans and business folks and so on. Because, you know, I think in the end there are a number of businesses that support, but it's a small percentage. I'm actually glad it was canceled because I'll get home fairly late tonight. And 8 in the morning, I was supposed to do a debate with Matt Dean, the House Healthcare Committee Chair, before the White Bear Chamber of Commerce on healthcare. And I will speak to any business group, any other group, because I think this would be the best thing for them. And I say that I'm not a business guy. I'm not a business expert. I just listen to what people say, and I can guarantee you, I hear a lot of grumbling about taxes. I hear a lot of grumbling about other things. There's a study in 2010 of Minnesota employers. It was 150 or so employers. They surveyed, this was shortly after the recession, what's your number one obstacle? Why aren't you adding more jobs now the recession's over? Number one obstacle was not government regulation. It was not taxes. It was not employee shortages. It was employee health care costs. The number one, that doesn't say, they weren't all saying it was the most important one. It was the one most frequently mentioned as the biggest obstacle.
You say this is for all Minnesotans. Can you define Minnesota?
That's a good question, because these are the tough questions you have to deal with. What we would be doing is, first of all, if you're not close enough to the borders of this, but Hudson, Wisconsin folks, a lot of them work in the Twin Cities. And what we would be doing is saying, first of all, you're a Minnesotan, and I'll get to a couple other things on that in a minute, but we'd be covering anybody who lives in Minnesota. We'd be covering you. If you work in Minnesota, because the employers, there are two ways we'd be funding it. The portion that we have to add to the funding, because the portion that's replacing the premiums and the deductibles and co-pays, that would come from individuals and employers. It'd be individuals that have premiums based on ability to pay, and employers would be a payroll tax. And so Minnesota employers would be paying that, and that's a very real hit, and they'll complain about that, and they won't like that, but they're already paying coverage. Most of them are covered by employer mandates, and I'd argue they're going to get better coverage and cheaper. But so if you're working in Minnesota, your employer is paying into it anyway, and we'd be allowing people in those situations to buy into it. If you're traveling out of state, we do it the same as any insurance plan now. If you're traveling in Florida for the winter and so on, the health plan would be paying those Florida providers the same way Blue Cross or whoever covers you now does it. What about people wanting to come here for health care? First of all, I would argue this is a huge job creator because of the fact that you look at that Fix-It movie, you'll see employers talking about what a difference that would make. That's why I was saying, let's offer that to Amazon. You know, they said we want communities that think big and creatively. I thought, instead of saying, we'll hand you more checks of dollars, let's fix a problem you face. But it would, I think, would attract employers. Obviously, one of the issues, and we'd be asking for a federal waiver on this, is if somebody in California, they got cancer and they can't get coverage there, and they're going to come to Minnesota where they can get coverage. We want to be able to bill those states for the approval of it. We'd be asking for a waiver to do that. A few years ago in Minnesota, Hennepin and Ramsey County saying our hospitals take so many people from elsewhere in the state, we should be able to bill back other counties. And we do systems like that. We'd be asking federal government to do that. But we would be covering all Minnesotans. And that raises, I'll get to one more complicated thing, but no, go ahead.
I was just going to ask, there's the health care bill, of course, at the Capitol, the United States Capitol right now that's being bandied about.
Right.
And one of the things is supposedly those two senators, one Democrat, one Republican, came together, and they're doing something that will affect the waiver process, supposedly, that states apply to for the federal government. It's very convoluted right now, and they're saying it's going to streamline it. Would that help?
It would help. It would help. I don't want to pretend when we say, oh, we just go get these federal waivers. I'm not trying to pretend that's an easy step. I'll say passing the bill itself is a bigger challenge. But yes, we'd be asking for, and you know, when you think, I can think of so many obstacles to this. I can tell you, oh, this doesn't have a chance. But then you look at what we're doing now. It doesn't have a chance either, because we can't keep doing it. And nobody has any other ideas that fix it. And if we have one that works, I'm a big believer that the American public is not dumb. And if you put out something that makes sense to them, I mean, I've done some things that took 20 years for them to pass. I was proposing with drunk driving, I proposed a .08 blood alcohol level before any state had it. I couldn't get it through liquor lobby and others said, it's unreasonable and so on. We were the last state, the 50th state to pass that. But sometimes things come around and it takes time. It would be extremely difficult to pass, but yes, that waiver proposal would help. The more they offer it, we'd still need some waivers that may require congressional action as well as administrative changes. But I say we push for it. And I will go on, go ahead.
Oh, I was just going to say, with the Minnesota Health Plan, would that be able to help control costs of medical care and prescriptions?
Yes, in addition to the administrative savings, so the school example, one of the biggest things in there is the rationality of pricing. The example I gave about 3-to-1 disparity between what I and my insurance company paid for back surgery, neck surgery, and what somebody who's uninsured would pay for it. There was a study out a couple of years ago from Yale that was the New York Times headline about it, criticized a lot of healthcare reforms, saying what the experts said would save money in healthcare was wrong. That was the New York Times headline. One of the things this study from Yale said was he was talking about our weird, bizarre pricing system in which he actually calculated some type of, I think it was knee surgery. It wasn't knee replacement, but some kind of knee surgery. The price range that he found in hospitals around the country was $3,000 at the cheapest one and $55,000 at another one for the same thing. That's more than 15-to-1 price disparity. I don't know about your car dealerships here in Owatonna, but I don't think they charge 1/15 as much or 15 times as much as an auto dealer in Rochester. I think there's a little closer difference there. And why? Because we have zero logic in our system. There is no logic, and you can't know what it is. And people say, well, we should be able to shop better for healthcare, and you got to disclose prices. Well, how? I mean, the system is so incredibly convoluted, and having a rational negotiation system with it, it's not like the health plan is going to crush providers. Oh, we're going to just do it. Well, providers will say, heck, we ain't going to practice here, then we'll move to another state, we'll do that. You can't do it. You have to negotiate a fair price for them. And so you're going to have, both sides have some negotiating clout, but you negotiate reasonable prices. With things the way it is now, there is incentive for providers, for folks to charge more because they make more doing it. And there's a really thick book, if you're really interested in this. Elizabeth Rosenthal, who was a Harvard doc, worked as a reporter, health reporter for New York Times. Now she's head of Kaiser Health News in California. And she wrote a book called An American Sickness. And she talks about one of the many excellent stories. She explains the way things work. A patient who was, I think, a New York City school teacher, had some complex condition. He'd have to get a shot every 3 months or so, and it was like $2,000 a shot. And somehow his plan switched hospitals. He went in for one, and he got a bill for $20,000. It didn't really matter to him because his copay of $25 or $50 or whatever didn't change. But he said, this is outrageous. He doesn't want his insurer to pay for it because the schools are going to end up paying for it and everything else. And so he calls the insurer, he calls the hospital, and they say, no, it's just the cost. And so he calls the insurer, and surprisingly, the insurer doesn't fight it. He says, it's $2,000 at the other place, which may have been a jacked up cost, but it's $20,000 here. What for? And they, in the end, don't. And their point was, the Elizabeth Rosenthal's analysis is that they have to spend most of their premium dollar on healthcare now. They can have 15% loss ratio, which is their costs and their profits out of it. So if they want to make more money, the only way they do it is have higher premiums. And it doesn't really matter the way our premium system works because it's so convoluted. But to me, the single biggest thing outside of the administrative costs is you have a rational pricing system. I talked to one doctor in Mankato, a specialist of some type who I didn't know would do MRIs, but he said if I meet with a patient for a consult, I don't know if that's half an hour, 40 minutes, whatever, he says the cost is, this is 6-7 years ago, he said the cost is $150, $160. He makes off that. He says if I write a referral for an MRI, I get another $150 out of it. He says, that's ridiculous. I mean, that's what the consultation is for. But we got a system in place now where I refer you to this clinic. It's good for all of us. And so you would save a ton of money that way. So you have a few more questions. Yeah.
In your opinion, will anything happen in healthcare on the federal level?
At this point, will anything happen at the federal level on healthcare? I'm hoping not, because I'm afraid anything is going to happen this year would be terrible about it. But I don't know. I think there's a good chance they'll do something. When you have a group of people who spent 70 attempts to repeal the Affordable Care Act when they had a president who was going to veto it, now they've had almost a year with a president who won't veto it, who wants to sign it, and they haven't passed it once. You know they're struggling. But I think they'll probably find something. I just worry about what's going to happen in the meantime. Because I don't think the goal is to take people off health care. As I said, people don't stop getting sick when they don't have health care, and so on. So I have one more point I wanted to get back to. You were asking about who's a Minnesotan and so on. And I'll say I'm trying to take on all the hard issues, because plan's going to be attacked at some point for all these things. Oh, costing jobs, or doing this and so on. I'll take one, and I'll use the illustration of how President Obama handled it, which I'd say was the wrong way to do it. In 2009, when he was fighting for the Affordable Care Act, he asked for an address to a joint session of Congress. So things are televised nationally and everybody pays attention and so on. You wouldn't remember that except one incident that might make you do that. He was the guy who said he wanted everybody to have health care. He's addressing 435 House members, 100 senators, all of whom are politicians, all of whom are scared. Not all of them are scared, but politicians were kind of, somebody might defeat me if I say something controversial. And so he said, I'm not going to say something really controversial. And who is the most difficult population to talk about covering? Undocumented immigrants. And even though he said everybody should be covered, he said words to the effect of, don't worry. We're not going to cover people who are in the country illegally. Loud applause. No. This is what you might remember. Some guy yelled out, you lie, in the middle of a presidential speech. Now here you've got a president who says, and he talked articulately about his mom dying and how it ought to be something, nobody should have to worry about this. We should cover everybody, like education, it's the right thing to do. And he's saying now when it's his chance to do it, he's saying, but don't worry, we're not going to cover those people. What if he had instead, and he's attacked for backing off anyway, by saying he's lying. And the next day he said, by the way, it was until that time, what he meant by that was they couldn't buy into the public option they were considering. Next day his administration sent out clarification, no, we're not going to cover anybody, period. They can't buy through the exchanges either. What if he had taken a different approach and said, this is going to sound unpopular to you folks, but we're not going to let some kid who's in an auto accident, 12-year-old kid, bleed to death on the side of the road because they were born in Mexico. We ain't going to do that. We're not that kind of people. In fact, we do cover them. We take care of them in the emergency room. We take care of them in the hospital, the most expensive care possible. Why don't we cover them up front when it makes more sense to do so? He makes that argument. That's not going to win everybody over. Nothing wins everybody over. And he says, furthermore, if you think something is really dumb politically, I'll tell you what's really dumb. The idea that we're going to have people who work in our meat packing plants, people who serve us fast food at McDonald's, and because they were born in another country, we're not going to treat them even if they've got infectious diseases and they're handling our food supply. And you picture the audience in Congress kind of thinking, that's kind of a gross way of looking at it, but that's pretty true. So they're going to attack him. What are they going to say? You're telling the truth. That's a really vicious attack. But the point is we have, and I'll guarantee it's true in Owatonna schools, it's true in Roseville schools, we've got kids who are undocumented, and we're not going to say, well, we want to treat everybody for measles and everybody for this, except for those kids. Federal government's got to deal with immigration, but saying we're going to design a healthcare system that leaves gaps in it, that's the way you have infectious diseases spread, that's the way you have a lot of things. So I say that because I can guarantee you that's something people will attack. But I also think the public understands the logic of saying, let's take care of people because we're all in this together. If the person sitting next to me might have an infectious disease, I don't want that. If the person next to me may be chemically dependent, I don't want them untreated because they may be in the car on the road when I'm heading home and I don't want them there. And I want to treat people's chemical dependency things and so on. Anyway, that was longer than that. I'm willing, if there are any last question or two. But...
That was the answer. So.
Pardon?
That was the answer.
Okay. Anyway, but I do think we have to talk about those things. We can't duck on those issues. If you duck on the, my premiums. The premiums, I'm calling those ability to pay premiums, I'm calling them premiums. I will guarantee you some opponent will call them tax. And my response, I don't want to argue with them. I'll say, it's a free country. You can call them taxes. You can call them anything you want. I call them premiums because premiums are what we pay for health care. And instead of paying premiums to health partners, which is where I pay it now, I'd be paying them the Minnesota Health Plan. But you can be sure they'll throw every attack. Oh, socialism. When I told you about the US senators, 16 of them have signed on, including Al Franken signed on to this thing. He was a little bit timid about it. He said, when he announced it, he said, well, Paul Wellstone always supported that. So I think we ought to consider it. That's not a ringing endorsement. But I don't care because he did sign on to it. And, he had to sign on to it because people are going to say, what are you for? Well, we're for stopping what they're trying to do in Washington. Well, what do you want? Well, we want the Affordable Care Act. Well, that's what we got now, and that's what people are complaining about. And so you got to be for something, and so I'm for that. But why is he timid about it then? Because he's scared. Because, as I said, politicians are worried about losing elections. I've lost an election. I don't like losing elections. Nobody does. And so they're scared. And I can guarantee you, for having signed on this, even if he doesn't campaign on it, they will know he signed on to it, and they will attack him by saying he's for a socialist healthcare system. Never mind that Medicare or Canadian system or this isn't, single payer is not socialism. The VA is socialism. The British system is socialism, where they're all public employees. It's a public system. But this isn't. But they will attack him for socialism, and he's scared of that because it's a sticky charge. But I just try and remind somebody that, well, what did they call you when you supported the Affordable Care Act, which was an idea that came out of the Heritage Foundation, a conservative idea that the first politician that pushed was Mitt Romney in Massachusetts. They call him a socialist for doing that. He's a Democrat. They're going to call him a socialist, whatever he does. So they're going to attack him for that. But on the other hand, he's going way out on a limb to do this. And I think what he'll do is he talks about people are going to say, it's about time somebody talks about a sensible healthcare system. And when politicians hear people say something, they like it, they kind of, hey, I'm going to say more of that. And they say more of it. And they get stronger and they start talking about it in a positive way. And people say, yeah, they applaud. And people like that. And I actually think candidates, US senators like that are more likely to win re-election. I think it changes the debate, and then other people start doing it. That's why I have hope of the thing happening, because we have to have people who are willing to talk about these things. So anyway, you've been a very patient audience. Oops, one last one.
Just interestingly enough, I was just on the internet this morning because of a question my doctor in Mankato had asked me, what are you going to do in case of an emergency? Because I've got Medicare, but I don't have anything additional, no supplemental.
Right.
So I go on the internet and I'm Googling bankruptcy. The number one cause of bankruptcy in this country is
Healthcare.
medical expenses, and it's not just for the uninsured.
Right.
So use that for motivation
Right.
when you're educating yourself and politicians. We got a real problem in this country.
Most people who go bankrupt from healthcare have insurance. Yeah, that's absolutely the case. It's a good point. And no, we can't afford to do anything else. For moral reasons, for economic reasons. Who here has Googled the symptoms they have to see if it's something serious? I've done that. I've done that. And several years ago, when I was chair of the health committee, we had a hearing out in Mankato, and one couple, a farm couple, said they had a 10-year-old son, and they said, he was really sick one weekend. They took him to the emergency room because they were really scared. And it turned out to be nothing, but he said it was $500 out of pocket. And they said, we don't have $500. He said, next time our kid gets sick, what are we going to do? Do Do you wait till Monday? You're gambling, but I mean, what kind of system is that? You've been a very patient audience. I hope this is helpful. I'll stay around for a while, and if you have any questions, thank you. Thank you. That helps.